Welcome to committee. Please identify yourself for the record.
Good morning, Madam Chair, Mr. Co-Chair, and members of the committee. For the record, my name is Niklas Kleinworth, and I'm a policy analyst for the Idaho Freedom Foundation. Despite 35 states covering more than half of their Medicaid population under managed care, spending in the program grew by $146 billion between 2017 and 2021. If the goal of this committee is to finally put Medicaid on a sustainable budget, managed care misses the mark. Nationally, managed care demonstrated lackluster performance in controlling medical welfare spending across the country. Among states that covered at least 50% of their population by comprehensive managed care programs, there was no significant distinction between managed care states and the rest. Overall, states appear to end up in the same place, regardless of whether they used managed care, growing Medicaid costs with little control. There are many examples of states with managed care like Louisiana and Georgia, and without, like North Carolina and North Dakota, that range across the spectrum of cost growth. Now, Sellers-Dorsey reported Nebraska and Utah as model states for Idaho to emulate, but both states did not see lower costs due to managed care programs. Utah's total Medicaid spending was virtually identical to Idaho's at a much higher cost per beneficiary. Utah spending per member per month grew more than 2 points faster than Idaho at a compounding rate of 6%. In Nebraska, we see a very similar story. Nebraska saw a much higher cost per beneficiary, and pre-COVID and expansion, the annual average cost per beneficiary was 16% higher than that in Idaho. Managed care did not appear to contribute to improved budget stability either. Both Nebraska and Utah had to pass supplemental appropriations to cover the costs of their Medicaid programs. The chart shows how spending in most states is moderately predictable regardless of the management system. In all, managed care has no cost control because it ignores the main drivers. In all states, Medicaid expansion was the strongest driver of budget growth. In Idaho, this program costs about 2.5 times more than what Millman predicted it would cost in 2018. Prescription drug use drives costs too, with claims outpacing enrollment by 50%. Though the prescription drug benefit is optional, Idaho has little autonomy for what should be covered. Ultimately, we are left with record spending on a population dependent on government for drugs, particularly for mental health. There also exists a pseudo-expansion for ineligible enrollees. A DC news outlet noted that Idaho is one of 9 states that agreed to stop removing people from the rolls for procedural redeterminations. The legislature should demand an answer from IDHW about this and how the department intends to finish the pandemic unwinding on schedule in December. Thirdly, provider billing practices demonstrate a lack of integrity in the system. CMS data reveals that 2 in 5 payments made to Idaho providers are improper. This is about $1 billion. Even if most of these are simple errors, this brings up some serious questions about billing practices. Currently, there's a data gap in this area that requires investigation into how much money we're actually losing. So what should the Idaho legislature do to address the rising costs? The solution is simple. Idaho must address the 3 components of an iron law. First, Idaho must expeditiously remove ineligible enrollees from the program and repeal expansion. This addresses the fact that Idahoans were undersold on the cost of Medicaid expansion and preserves the program for the truly needy. There also must be efforts to address service costs. There should be a full forensic audit to identify how providers are billing for Medicaid services and where improper payments could be prevented. Finally, there should be more accountability for service use. The state should push back against CMS's all-or-nothing approach to Medicaid prescription drug policy. This may entail a change to offer the program for the truly needy at the state level instead of from federal top-down. To summarize, switching to managed care will not be the solution to Idaho's Medicaid budget woes. The system does little to control budgets, necessitating a return to the iron law of Medicaid cost control, reducing enrollment, reducing use, or reducing service costs. Otherwise, you can expect that we'll have the same conversation in this committee room 3 years from now, with taxpayers still facing insurmountable costs. Thank you, and I'll stand for any questions.
Thank you. Questions? Representative Healy.
Yes, thank you, Madam Chairman. Mr. Kleinworth, Can you elaborate on the 2 and 5 improper payments? That's a large number. Can you tell me more about that?
Mr. Kleinworth.
Madam Co-Chair and Representative Healy, thank you for that question. This is information from the Center for Medicare and Medicaid Services. This did not come from the Idaho Department of Health and Welfare. The latest audit that they did was in 2019, where 39% of the payments that were issued to providers were improper. This is either from providers that were either payments made for beneficiaries that weren't actually eligible for the program, or billing errors where they were billed for services that weren't actually provided, or the services didn't match the code completely.
Follow up?
Yes, thank you, Madam Chairman. Were those costs brought back, I guess? If they know that they're out there, wouldn't those be brought, like, recaptured? Thank you.
Mr. Kleinworth.
Madam Co-Chair, Representative Healy, thank you for that question. We don't have enough data on that to truly know how much of that money was actually brought back.
Right.
Another follow-up?
Yes, thank you. One more. Mr. Kleinworth, the RX costs, can you elaborate on that more? When I look at prescriptions, oftentimes those are what are preventing patients from going into the hospitals. You know, you look at hypertension medications, that's what prevent patients from having strokes, high cholesterol medications, et cetera. What would you suggest would be an alternative to prescriptions?
Mr. Kleinworth.
Madam Co-Chair, Representative Healy, I'm not necessarily recommending an alternative to prescriptions. I believe that point wasn't entirely accurate. So the issue here is that the argument is that the prescription drug benefit is the fastest growing component of the Medicaid budget. But it's driven by use. It's not driven by the cost of the drugs themselves. 1 in 5 prescriptions are for mental health drugs or psychotropic drugs. But the problem is that we're not talking about people who are needing hypertension drugs or people who need diabetic medications. We're talking about people who are maybe needing to use the system for other things.
Yes, sorry, one last one. So if I'm understanding this correctly, an antidepressant antidepressants, in my opinion, would cost less than a psychotropic hospital admission, which would be the point of them. But you're saying if we don't pay for those, we'd save money?
Mr. Kleinworth.
Madam Chair, Madam Co-Chair, Representative Healy, that's not what I'm saying. What I'm saying is that we have a problem in this country where people are dependent on the government for their drugs, and a better system would be to find a way for these people to not have to use these drugs.
Senator Zeiderfeld.
Thank you, Madam Chair and Mr. Kleinworth. And you only have a short time, but I was wanting you to go a little bit deeper on the MCOs don't promote budget predictability. Can you maybe explain that in just that short time a little bit deeper for me?
Mr. Kleinworth.
Madam Co-Chair, Senator Zeiderveld, that particular graph, what I was showing was a regression analysis of the budget growth for all 50 states. And so what you see is that in a short period of time, you could predict a budget on a linear trend within a reasonable margin of error. What you find is that for the majority of the states, regardless of the management system, the management system did not improve budget predictability.
Representative Tanner, you've got 30 seconds.
All right, thank you, Madam Chair. Mr. Kleinworth, you had mentioned for 9 states that were kind of forced back, or a news article that forced them to stop us from the unwinding process. Can you just elaborate a little bit more on that?
Yes.
Kleinworth.
And Madam Co-Chair and Representative Tanner, in the 10 seconds I have left, I'll just mention that this was for procedural redeterminations. This is about 44% of the people who were disenrolled. We need to investigate more as to why that was stopped.
Wow, you did really good. Right on time. Thank you.